is a huge honor today to be podcast interviewing Dr. Ronald McGlennen, an MD pathologist, and he is the founder of OralDNA.com. I'm so excited he accepted to be on my show today. This is absolutely mind-boggling stuff he's been doing. Dr. McGlennen is president and medical director of Access Genetics and OralDNA Labs. He has published more than 75 articles and book chapters and has served as the editor of 5 journals. He holds 9 issued patents. He is board certified in Anatomic and Clinical Pathology and also by the American Board of Medical Genetics with a specialty in clinical molecular genetics. He is internationally recognized as an expert in molecular biology and genetics. His focus in research has been on reducing the complexity of gene-based testing, including DNA chip technology and simple analytic instrumentation to better serve the community laboratory. He has served on a series of governmental and regulatory committees focused on the growth of the field of molecular diagnostics. Through his interest in OralDNA Labs, he hopes to bring the power of the clinical lab to the forward-reaching dental practice. This is like Star Wars stuff, isn't it?
It used to be Star Wars. It's actually still meat and potato medicine.
Is it really?
It is, and I think that's what we have to start this conversation with, Howard. It's meat and potato because whether we're talking about genetics or measuring a blood marker, you know, the laboratory is central to how we make modern diagnoses. It's how we take care of patients and surveil what is working and what's not working in terms of therapy. And increasingly, it's about what we share with patients before they have evidence of disease. So we prevent, we diagnose, we prognose, we monitor. All these things happen through the kinds of stuff that we bring to you as a clinician in the clinical laboratory. So the Star Wars part, you know, is discussion about DNA. And I guess maybe I have a little bit of a different perspective. I've been doing this for 25 years. And I remember when my mentor told me, you know, if you want to waste your time in your career worrying about DNA, so be it. But here I am 25 years later, and it's really becoming part of the everyday conversation. So don't be overwhelmed by the idea of molecular or DNA. Let's just talk about what that kind of information does to take care of patients.
So the United States has 211,000 Americans are alive in America today with a license to practice dentistry, and there's 1 million physicians. Would you say that dentists use DNA testing and molecular genetics a lot less than their MD counterparts?
Yeah. The term "a lot less" doesn't even begin to fit onto the scale, and so without a question, my mission in my career, notwithstanding my business, is to provide quality DNA and, if you will, laboratory testing. But sort of shoulder to shoulder with that mission is to bring to the world of dentistry some of the very important principles that most physicians use every single day. They start conversations with patients, they order a lab test, they amalgamate that information, and together with their clinical exam plus this laboratory information, they reach a higher level of understanding. I do not believe we have that in dentistry, and it is part of my mission to help that come to be realized.
Well, one way to fix that mission is create an online CE course on Dentaltown to show them, you know, how they could be physicians of the mouth instead of working with their hands and just being surgeons all day. I mean, most of them think they're helping you if they have a burr going on your tooth and they're fixing a tooth, and you're telling them to stand back and be more like a physician and order tests.
You know, one of the beauties about dentistry that, you know, a physician doesn't fully appreciate is the art of it all, and the art of not only the therapy that you apply, but the very pointed clinical exam. I'm not in any way dismissing the significance of that. Rather, to the contrary, I wish physicians would spend more time in the physical exam and less perhaps on the reliance of outside information. But we live in a time when we can see much, much deeper into the disease process if we incorporate some of these tools. So that's why we've used some of the things that sort of bring this into a more familiar context. We talk about our DNA-based testing as molecular X-rays. I know it's a word, it's a phrase, but frankly, it sort of brings it into the context because most dentists do use X-rays. They can see into bone and tooth structure, and they can look for pockets of infection. beyond that, the laboratory can start to tell you what is the nature of that infection and what is the severity, and is it actually just an empty pocket or is it filled with pus, and all these things that your eyes can't do, your x-ray machines can't do. So bring in this other set of tools to make it all more enhanced.
I've been interested in DNA-based testing because my four boys are 21, 23, 25, 27, and they're all taller than me and good looking. So now I'm wondering if they're even my children.
You understate your good looks.
I think, Ryan, I think I might not be your father. He's 6 foot tall. How could this 5'7" short guy have a 6 foot tall son?
We call them a mutation.
They're mutations. The reason the show's an hour is because they all have an hour commute to work. So they're driving to work right now. Start walking them through real life dental clinical scenarios and where they should be doing this. And would they do this on your website, OralDNA.com?
That's correct. So on our website, OralDNA.com, there is an opportunity to then log into our secured portal, which is where we communicate back and forth laboratory results. The process by which OralDNA becomes part of your practice is a simple phone call to our customer service. They'll send you out some collection kits, some instructional material embedded into an introductory email, and you're up and running.
Okay,
so
is this just all saliva, or is there blood? What fluids are you testing?
Right now, it's saliva, and I guess to be more specific, it's saliva with some salt water. So we call it an oral rinse. So let's start there. We collect a sample of saliva admixed with 5 milliliters of saline. So what does that tell us? Well, in that collection, if you close your eyes and imagine what it is, don't close your eyes if you're driving to work, you're going to be collecting some of the sloughed epithelial cells. In those epithelial cells from the patient is the DNA material in every single copy of those cells that makes up our entire genome. So that tells us a lot about why we're tall and short and whether or not you challenge your boy's, parentage. Okay? Now also in that sample is bacteria. Bacteria have DNA also. And so we can get at that DNA from that same collection. Also in that sample are fungi and viruses. And we're going to talk about each of those cell types in sequence here. Let's start with the bacteria. So many of us are familiar with clinical microbiology. That is, stick a paper point below the gum line and let it dwell there for a few seconds. Bacteria will adhere to that material, and then you can send it off to a laboratory, and using a lot of specialized techniques of broths and cultures and some biochemicals, you might be able to ferret out which bacteria are present. Some of those bacteria are good, some of those bacteria are bad. So by conventional microbiology, we have some opportunity to find out who the good and bad bugs are. With DNA technology, the process is vastly simpler. DNA is very durable. It transports readily from the chair side to the FedEx box to the clinical laboratory, so don't worry so much about degraded sample, whether it's misrepresenting one species versus another. So putting that oral rinse sample into a tube and shipping it off to the laboratory is a cross-section, is a view of what bugs are present in that patient's mouth. Then we use the power of our testing technology to sort and quantify the good and the bad bugs. The same sample is a good place to collect human DNA. And so let's talk about what human DNA might tell us about oral pathology. Well, we have an immune system, and we know that by definition, periodontal disease is more than just the presence of the bacteria, it's the body's response to that bacteria. We are different between us as individuals in the pronouncement of that severity of inflammation. Some people have their thermostat turned up way high, so they have a lot of inflammation, and some people have a more sort of normal or demure inflammatory response. And we could go down the list and say, what are we looking for? Bugs, viruses, fungi, or something in the human genome? Simple collection process goes off to the lab. So let's walk that sample through. You go online, you enter in the patient information. You say it's a 50-year-old male. He's got mild, moderate, severe periodontal disease. You've done so by placing that ADA classification. Maybe you've measured pocket depth. You tell us something about that patient. Are they diabetic? Do they have heart disease? Are they a smoker? Are they on an antibiotic? Are there other medications that we can bring into the whole picture? That gets transmitted through our web portal in a secured fashion. The sample collected at the chairside gets sent off by FedEx, and they meet here at our laboratory in Eden Prairie, Minnesota. We open up the bag. The first step in that journey is to take from that sample of saline and saliva, spin it down, and we're going to get DNA. DNA from the cells, DNA from the bugs, DNA from the viruses. Generally, what we do with that DNA is subjected to a particular technology called polymerase chain reaction. It's a way that we can target selected regions of those genes or genomes and raise them up to a level of dimension or quantity that we can then readily measure them, analyze them, look at their sequence and whatnot. I look at that information along with my colleagues who are expert in this area, and we assemble a laboratory report. We hit a button on our computer, and the next thing is it appears on your web portal in your office instantaneously. Everything between collection and report is all about the work we do for you. We want to be viewed as a partner to your practice. So we strive to do it as fast as possible, 2 to 3 days between collection to answer, including the transport. We're available to consult about what those answers mean, but we'll get to those answers now. One of the tests that we offer measures those bacteria which are known to be pathogenic or pathogens that cause periodontal disease. You've told us that this patient has swelling, maybe some enhanced pocket depth. Maybe the x-rays show some bone loss. But you do not know the nature of that infection. These test reports will tell you the nature of that infection. Which bacteria are involved, what's their quantity. From that information, we'll tell you, amongst other things, that there are some choices of antibiotics that can be used. It's not one size fits all. There are a matrix of maybe 10 or 15 different drugs in different combinations for different regimens. And so the bacterial profile or the bacterial signature, which is frankly unique to every patient, will have a unique or personalized answer for your therapeutic action. Let me underscore that one more time. We live in an era of personalized medicine. But when you talk about that in sort of general terms, people their eyes kind of glass over. But here's a very specific example when you're talking to your patients. I am doing this test to identify the precise and customized therapy that will be useful to cure your infection. That's a great example of personalized medicine. It's as cutting edge as anything we would talk about in cancer therapy or other advanced disease states. So keep that in mind. When you do this type of testing, you are personalizing medicine for your patient.
If a physician saw 100 patients, an MD, out of those 100, how many would they run tests? Ask for blood, urine, something to test.
My experience, about 100, maybe 99.
And if a dentist saw 100 patients, how many of them would she order tests on?
3 or 4.
And where do you think that's going to be in the future?
Through our efforts, 50 or 60.
And how much is that test?
Well, the test to the dental community is $99. The opportunity to the dentist is whatever you market to and whatever you sell it to your patients at. We don't have really qualified data, but we know that it runs around $150 to the patient themselves.
Are any dental insurance companies starting to cover this?
Yes, and medical insurance companies as well. And as part of the transmission of these results, we share with you the codes that you might apply for dental insurance or medical insurance. Since our business relationship with all of the dental community is through credit card or cash, that transaction with insurance is your advantage. But we provide you with that information to help you code this.
How many dentists are using your services now, would you say?
Well, it's really exciting is we've got about 6,000 dentists across the United States that are active participants in our laboratory services. What's even more exciting is that about 2 or 3 offices are signing up per day.
Nice.
And I think we do a really good job of taking care of our customers, not only through friendly and user-friendly approaches towards signing up, but just the simple convenience of running samples through, getting results, and when you need us, we have instantaneous response to consultation. We'll look things up. We'll do background work. Let me talk about that for a moment. I have no pretense here that the handful of tests that we offer are going to cover the waterfront for all questions that a dentist might experience. But let's be very clear. The dentistry community sits in a very privileged chair. They see patients who come with a host of conditions, and they may be more hesitant than to go to their physician to get that diagnosis of diabetes or high blood pressure and maybe even a malignant process. So you sit in a privileged position where you can ask questions. And through some of these laboratory tests, you can start to identify not only what's going on in the mouth, but what's going on elsewhere in the body. So let's go back to the topic we were just talking about, measuring bacteria that are causal for periodontitis. I hope there's no questions from your audience that these same bacteria are, through a process of time and quantity, they leach into the bloodstream. They cause transient bacteremia. And those bacteria fall on end organs that include the coronary vessels, the brain vessels, the pancreas, and, if you will, even our joints. These are causes of systemic disease. And so there's much to be talked about in terms of the role that these oral bacteria play in the initiation and the progression of atherosclerosis, of type 2 diabetes, of the various arthritides. So we live in a day when we talk about the oral systemic connection. And the dentists who are on the vanguard of this have formed organizations that are very much in discussion about this. How does the dentist play a role in finding this disease earlier on in younger people? So let's talk next about where we're going with this. I just shared with you an example of how you might use this test to confirm a diagnosis of periodontal disease. But let's be very clear. There are people out there who do not have clinically observable periodontitis who have these same bugs. And you owe it to them to bring it to their attention that they are also at risk for these chronic diseases. Part of personalized medicine is preventative medicine. Our job is to find that 20-year-old who is going to have heart disease at age 50, who doesn't feel it now, but has an opportunity to start changing their lifestyle, their diet, and so on, to then stave off some of these chronic disorders. This is the new vanguard of medicine, and it starts in the place where most people get their first foray into healthcare, their dental office. So it's a privileged position that takes on a whole new scope of responsibility, and all it really takes is to start a conversation with us, start a conversation with me, and we'll walk down this path together.
On Dental Town, there's a 250,000 member dentists on here, and there's 50 categories: root canals, fillings, crowns, what have you. But under health, we have a thread, we have a section called the oral systemic health, and it has exploded on Dental Town, and it's exploded with a lot of controversy because some, in fact, I wish you would just spend, oh my God, if you would just spend a day going through these oral systemic health as an MD pathologist. Plus, whenever you answered a question in your signature, they'd see who you are and that you're an MD and a link to your website and all that stuff. But I mean, the periodontist can't even agree if periodontal is really associated with other parts of the body. What would you say to those people who say it's possible, it's probable, it might all be true, but there's zero evidence that there's any association with this stuff?
Well, first of all, I would simply stop that sentence by saying there is zero evidence. There is ample evidence, but let's put it into right perspective, because I think you're absolutely correct. Part of the responsibility of understanding how to use the clinical laboratory and to assemble a larger portfolio of data around your patients and around patients at large is to know how to interpret this information. So let's start with a couple of vocabulary words. Risk. What does risk really mean? We grew up and we went to school in medical schools and in dental schools where we talk about patient comes, they have disease, get rid of the disease. So the presumption there is that they come to you with some degree of illness. But now we live in an era where through these tools, x-rays and molecular tools, we can see disease at its very incipient forms. And sometimes the progression from the initiation to clinically, symptomatic disease may be measured in decades. So does that mean we just dismiss the conversation because it's not going to affect us between now and when they come back? No, we have an opportunity and a responsibility to do it. So talking about risk, I urge all of our listeners to talk about things like odds ratios and Wilcox test. You have to become familiar with those terms so that when you talk about them with your patients, they come out coherently. Risk means risk. You have to think of the world in terms of large populations and how that plays out through individuals. And through that vantage is how you communicate to patients. So let me give you a scenario. What do you say to a 25-year-old who smokes a half a pack a day and you were to measure these bacterial pathogens to find that they have elevated levels of Porphyromonas gingivalis? So you're not there to tell that guy he's going to have a heart attack in the next year. That's very, very unlikely. But you have to find ways to communicate words like you are at risk. P. gingivalis plus your smoking plus your lipids gives you the full package of your disease likelihood. And you can affect some of those things, and some of those things are harder to affect. Let me give you a more succinct example. Dentistry is very interested in the role they play in oral cancer. Finding it. You put your finger in their mouth, you run around, you feel for lumps and bumps, right? Did that bump change over 3 months, 6 months, etc.? Now we have a test that identifies the virus that is identified in 65 to 70% of oral cancers. I'm going to use a phrasing here which is sort of common to my personality, which is in the old days, 50s and 60s perhaps, laryngeal cancer, oral cancers were old man smoking drinking disease, right? You smoke too much, you drink too much, and if you get old enough, you might get one of these oral cancers. That equation has changed. Oral cancer is a disease of the 3rd and 4th decade of life. It affects men and women, and the cause of that is an infectious process. That infectious process starts somewhere, and in some people it goes nowhere clinically important, but in some proportion it goes to a very bad place. How will you know unless you test? How will you know? And then when you have that piece of information, a positive HPV test, what does that mean? That patient is at risk. Is it a huge risk? No. You need to have some perspective on that, and I can provide that. The literature will certainly share that. But you have done that patient a great service by telling them that you should not have multiple sex partners, or you should surveil that infection until it goes away, and because you have it means that you might need at some point some more sort of deliberate investigation of lumps and bumps in your mouth. It's that simple. We're not saying change your life totally, but we're saying we've got a piece of information, we can judiciously use it to manage your care long term. Risk is central to that conversation.
What I don't understand about dentists is that if when women went to their OBGYN or their doctor and they stopped doing cancer screenings for their parts below the waist, I mean, people would think that was crazy. But then all those girls go to their dentist and almost none of them do oral cancer exams in the mouth. Why are dentists so out there? I mean, what percent of female doctors test for cancer, vaginal, uterine when they go in for a physical?
Well, okay, so there's two parts to that answer, and so we're talking about the gynecologic community, and the answer is 100% of them are involved in some way in using a Pap smear or HPV, and HPV comes on the scene about 20 years ago and is standard of care. It would be, frankly, malpractice not to surveil that. So you make an excellent reference. We refer to it as below the belt and above the belt, and let's be very clear. What happens below the belt also happens above the belt. So there is no reason to not start that conversation. The second part of your question is you don't get onto the topic unless you ask that initial question. Patients are actually very open to the topic of oral sex, and they will share that with you. But the professional in the room has to initiate that conversation. So don't be afraid to ask the simple question. Tell me, would you mind sharing your sexual history? Have you engaged in oral sex? Have you had multiple partners? Have you noticed anything? Do you have any concerns? And when you do that, you'll find not only an important and intimate component to the relationship you have with your patient, but they will be very forthcoming about saying, yes, I do have concerns, because they've heard the stories. Movie stars and friends in the middle or prime of their life, now coming up with a disease that used to be old man smoking drinking disease. That changes the dimension. Again, you have an opportunity to really have a meaningful engagement with your patient through a simple request of those types of questions.
I know, but I'm going to tell you a reality. I mean, Ron, I've lectured 1,000 times in America since 1990, 1,000 times. So many dentists in Texas and Kentucky and Tennessee and Kansas and Oklahoma. I mean, they'd be mortified. I mean, just that they probably even never said the word oral sex for. In fact, it's probably hard for them to say oral DNA. They're, they're like oral DNA. So, I mean, talk to those guys.
You have a professional responsibility to enhance health, whatever your focus is. I mean, that's sort of the altruistic side of it. I think on, if you will, a practical, if not an economically driven side, I don't think there is any evidence to suggest that by asking important, intimate, and expansive questions to your patients will do anything but enhance your practice. It will bring more patients in your door. They will trust you more. They will appreciate your humble and noble approach towards the broader perspective of their health. The mouth is a window to the rest of their body.
It always gripes your gears when someone says, "Oh, you're a dentist. You're not a real doctor." And there's jokes out there. Like I'd always say, like, "Well, Dr. Pepper's not a real doctor. Dr. Dre's not a real doctor." But the bottom line is they're not a real doctor, because, like we were saying, if 100 women went to 100 gynecologists, they'd all get tests done for this. If those same 100 women went to their dentist, what percent of them would ask questions or run tests on them?
Well, I mean, if you want to put the responsibility wholly onto the patients, then that number will remain very small. A few percentage of them will come forward because they're not used to the experience of having a dentist sort of open up the dialogue of a host of things beyond teeth and gums. Okay? But I can give you my solemn assurance that if you ask, as the professional, if you ask the first question, you will be rewarded by a lot of people opening up. I have the very same doctors, and these are head and neck surgeons and oral maxillary surgeons, who a few years ago were chiding me for making an oral HPV test available, saying, "What are you doing filling my office with worried well people?" Today, those conversations have completely reversed. They're thanking me, saying, you know what, I'm identifying a few cancers. I'm really opening up this dialogue. So from where I sit as a pathologist, I am gratified by the service that we can now expand and extend to this host of new questions. It's important.
The famous people that came out with the oral cancer and tying it to oral sex, that was Michael Douglas, right?
Right.
And then there's a lot of talk also about a famous Buffalo Bills football player. You know who I'm talking about?
I'm afraid I don't. But
who's the Buffalo Bills? Anyway, they're talking to him, trying to get him to come out and talk about it, but I don't know if they're there yet. So you talked about perio, you talked about HPV, and I've been ranting for years that I think it's insane when about 8,000 to 38,000 people die of the flu each year. And you look at those people and say, what was their last point of entry to the healthcare system? And dentistry is first, second, or third. And here's a dentist and a hygienist cleaning her teeth. And I mean, what's the chance she's going to die from not getting her teeth cleaned next 6 months? Why don't you give them a flu shot? But in every state except one, except for Tennessee, you can go to CVS or Walgreens, and a pharmacy tech with 9 months of school can give you a flu shot or an HPV vaccine. And me with 9 years of college, it's against the law for me to give a flu shot. Dentistry, and this is why I was so honored that you would come on my show, because dentists need to get the right for flu shots. They need to get the right for HPV vaccines. They need to start running molecular tests like real doctors. They need to be physicians of the oral mouth, or they need to just sit there and say, hey, I'm a molar mechanic. I'm not a doctor. I'm a tooth mechanic. And if you have any doctor questions, you're going to need to see a real doctor. I mean, they need to differentiate themselves. Are they going to be mechanics? Are they just going to be tooth jockeys? Are they going to be doctors?
Well, I appreciate that. And I just wanted to comment that a lot of people say to me as a pathologist, what do I know about patient care? I don't see patients face on face. It's an attitude. It's a perspective. It's a mission. And so I know that people listening to us right now will resonate when I say, you went into this for more than just a handful of things that you see every day. Expand your careers, expand your mind, and expand your scope of influence through the simple step of opening your sort of doors to bringing in outside information that give us new perspectives on what you can do for patient care. And so let me highlight some of the things that we're not presently doing today, but we'll be doing in the near future through a laboratory service, which quite frankly is dedicated, devoted to the dental profession. I want to be very clear. We are a laboratory of the highest professional caliber. So I won't recite them, but all the credentials that we hang on our walls qualify us to say that we are validated, we are tested, we are compared. So you can trust us that what we're doing is the top of the line medicine. And so for that reason, we have a menu that has 8 or 9 different tests that you can order today. Periodontal disease, inflammation profiles, viruses, other types of bacterial infections of the mouth. But in the future, you make a point. Why wouldn't a woman concerned about Zika infection, a new epidemic in this continent, might have her first interface with healthcare through a test that could be offered out of the dental office? Why not? Is that to suggest that the dentist is not qualified to talk about the very next step, which is you're positive or you're negative? If you're positive, maybe you need to go see your internist, maybe you need to go see an infectious disease doctor. It's not that tough. But think of a number of conversations in the broader scope of topics we take on. We also know that there are a lot of things that you do in dentistry that are influenced by diseases ongoing in the body. And so, of course, there's conversation about measuring spot glucose and looking at blood pressures and maybe looking at reactive or inflammatory proteins. All these things can be done methodologically, so simplistically, from a saliva collection. And so that's what the future brings for making dentists a bigger player, a bigger participant in the medical community, doctors of the mouth, if you will. We'll help you.
So you said right now you do 9 tests?
That's correct, yes.
Will you go through all 9? You just said 3 of them.
Sure.
Go through all 9.
We talked about the bacterial test, and we have a couple of new versions of that bacterial test which get even more specific. And so we look, for example, at P. gingivalis and its various isotypes. We know that it's one bacteria doesn't explain it all. Sometimes there are strains that are more pathogenic than others. That helps in explain cases where the initial test, the so-called myperiopath, doesn't answer all the questions. The second area of testing is the human genome. We have a couple of menu items, and they are entitled tests like MyPerioID is one name, and the other one is called Celsus-1, and I'll get to why that is named in a moment. This is looking at a profile of human genes, a profile that identifies those who have a tendency or a proclivity to have a more pronounced inflammatory response. You've got relatively few bacteria to explain a case of periodontal disease. Well, many of my colleagues point out that individual is having a very pronounced inflammation to a relative paucity of bacteria. That explains that patient against the backdrop that there's so many who have high levels of bacteria. That's one application. So Celsus-1 and MyPerioID. Why do we call it Celsus-1? I'll tell you why.
I know why.
Please, you looked it up, didn't you?
No, no, you're in Minnesota, and my oldest sister's in a nunnery in Lake Elmo, and I think it's absolute zero is minus 273 degrees Celsius, and that's probably the average temperature there in January.
Well, it used to be when I was growing up, but not so much anymore. And we struggle sometimes to get it below freezing. But close. But it's not Celsius, it's Celsus. Okay?
Okay.
Celsus is from the Roman time. He was an encyclopedist and a physician, and he is the one who coined the Calor, Ruber, Tumor, Dolor. You know what that is?
Tenderness, red swelling, tenderness, pus, or pain.
You pass the 4 cardinal signs of inflammation.
Go through them.
So Celsus is named after a test that is looking at inflammation, and so whimsically, it's about those 4 cardinal signs of inflammation.
And what were they? Go through the 4 in Latin.
Calor, like calories.
Calor, like calories. Pain.
Ruber, redness. Let's see, calor, dolor, tumor. Tumor means swelling.
Tumor, swelling, ruber, redness, pain, and then calor. What was calor? Calories? Temperature?
Yeah.
Okay.
Heat.
Yeah, temperature, heat. So it was calor, pain, ruber, and tumor.
That's right.
From Celsus, the Roman physician.
That's right.
Nice, nice, nice. You're a creative mind, aren't you?
Well, I think my partner and I are pretty creative, but there's your cocktail hour conversation starter.
If you remember that from dental school, you didn't drink enough beer in dental school.
Maybe so.
Okay, so you talked about...
Okay, then we go on to HPV. So we have a test to detect the virus for HPV. We also have a test for herpes simplex virus. And I'll get back to that in a minute. We have a test for chlamydia and Neisseria. Basically, clap of the mouth, because it does exist and people are worried about it. We have a test that identifies the different types of candida or yeast, okay? Because it matters on your choice of antibiotics. And then lastly, we have oral cytology. So we can collect a sample and combine these molecular markers with what the cells actually look like. So let me give you a scenario. You've got an aphthous ulcer in the mouth. You presume that it's herpes simplex virus, right? But maybe it's actinomyces. Maybe it's actually an invasive candida infection. The difference between treating it with an antiviral versus an antibiotic or an antifungal is relevant. Now, the algorithm is You could test for herpes simplex virus. If it's negative, you presume it's a bacteria or a fungus. If you don't want to look at those things, go ahead and do oral cytology. Same oral rinse, we'll look at the cells, and if you find fungal elements under the microscope, you've got the diagnosis. You went from the clinical observation of a sore in the mouth with the presumption that it's viral, but maybe not always, and then you use the laboratory to discern and establish the diagnosis, and now you have no reason to treat wrongly.
You know, the BBC, August of 2016, ran an article that was posted on Dental Town, could mouthwash combat gonorrhea? And, I mean, dentists, they need to get more in tune with this. I mean, people were shocked to find out that, dentists were shocked to find out that people are walking around with gonorrhea in their mouth, and that Listerine actually is one of the tools to use before and after oral sex to help combat gonorrhea. And dentists are literally at my seminars, and they're like, are you kidding me? I mean, they really got to change their mindset.
You know, common things happen commonly and rare things happen rarely. And so back to our mission. I mean, I have no pretense that there should be routine surveillance of chlamydia and gonorrhea from every patient you see, but you do run into patients here and then, and we want to be that laboratory service that addresses those needs when they arise. And correspondingly, over the last 2 years or so, the anecdotal cases of I have a patient with oral thrush, but it won't go away, and I've tried metronidazole, I've tried amphotericin B, you know, and so on and so forth. And so I asked the question, do you know the species of Candida that's involved? And they say, well, no, why would it matter? Because these different species harbor antibiotic resistance to variable degrees. Laboratory can give you that precise answer.
Yeah, I mean, you really got your work cut out, but I think you're doing it. I mean, you already have 6,000 dentists using you. You're on a podcast talking to several times that many. I really hope you create an online C course to really go through this methodically. And also, I really wish you and your partner would go on the forums under the Oral Systemic link and start chiming in on some of these questions. I mean, the dentists have, they know what they know, but they don't know what they don't know, and they're practicing in ancient times. That they need to get up to speed.
Well, I think I prefer to say that one of the ways we've tried to organize our business is to say that the laboratory is the resource, but we really do a good job of trying to provide consultation on these kinds of questions. And you'd be surprised at how many times I'm out bird dogging all kinds of unusual questions to help, you know, facilitate that conversation. Everything from rare genetic disorders, and where does that fit into the oral health picture that this hygienist or this dentist is seeing? I'm trying to provide some conversation as well as some lab results that make this a fuller, richer experience, and we take better care of patients.
Well, you know, instead of answering that one-on-one, you should tell them to ask you that on one thread. You should go to the Oral Systemic link and start a single thread and say, you know what, I'll answer you, but I wish you would ask this on that thread, because when you post a thread, then they can forward it to you, and then you'd answer that person, but then hundreds, if not thousands of others could start reading this, because it's going to be,
You got a deal.
So what would you say the dentist listening to you right now is saying with regards to cancer? No, I don't need any of this. I've already got it covered. I got a Velscope. I got, you know, some of these toluidine blue Velscope technologies. What would you say to that dentist?
Well, there's a couple aspects of it. First of all, we know very deliberately that not all HPV infections are the same. So the Velscope will identify established proliferations of cells. It doesn't specify whether or not the underlying viral cause, presuming there is a viral cause, is going to go off in the direction of a malignancy. So to those listeners, I'll point out that HPV, it's much more common to find the so-called non-oncogenic or low-risk types in the oral cavity. And to those patients, you can say, we're going to snip it out, We're going to watch it, but it's a low risk of cancer. Much, much more insidious are the infections that are the high risk. They are silent until they appear. And when they appear, they are typically established malignancies. And they're flat, and they're not so clinically observable, and the veloscope will miss them because they are in nooks and crannies that are not so obvious to find. So that's the first point. Test will reveal the relative risk. The other thing is, though, is that patients are interested in knowing about their baseline risk really early on, post-exposure, and often years in advance of any lesion being identified. Do them a favor and make this test available to them so that they receive those results with professional counsel that goes with it.
When you have two sisters that are nuns, you always think about the religious effect on the mind. And everyone knows you transmit diseases below the belt. But when you go into a dental office, they'll see a woman every 3 months for 10 years for gum disease. And they'll never have laid eyes on her husband. And I'm like, do you not realize that they're kissing in bed? Now, if they were seeing him every 3 months for chlamydia for 10 years, within 10 years, the doctor would say, hey, are you sleeping with someone with chlamydia? Can we get your husband in here? I think your husband might be carrying this. But then a periodontist will look you in the eye and say, well, you can't transmit periodontal disease in saliva. It's like, so you're saying that bug evolved there? What? When the kid was born, periodontal,
spontaneous.
What? Some 100 million year old evolution took place on this infant's tongue. I mean, where the hell? I mean, if you saw a giraffe in the backyard, you'd know it came from somewhere. I mean, how the hell could you not think that, so these bugs and all kinds of bugs, why do you, I'm just trying to get the dentist to say, no, I can't treat you for an oral disease unless I see who you're trading spit with. So I need you to bring in your husband, your boyfriend, the UPS man, the milkman. I need everybody you're making out with. You got to treat the village.
Well, I think this brings up the whole larger conversation about appreciating the biology of the oral microbiome. You're right. It doesn't come from outer space. It's part of the environment. Sometime after we emerge from the womb, we acquire our own oral microbiome. One of the things we clearly see in all the patients we test is a very idiosyncratic signature of bacteria. No two persons are exactly alike. However, within selected bacteria, when you treat person A and you knock down bacteria B, and then they go home and come back 3 months later, and if you have the opportunity to test their spouse, their child, you will see the co-presence of that same bacteria. So we have clear evidence day to day in our laboratory that people share the same microbiome. And by the way, if you don't believe us, I can refer to an article that points out that even within our own household, we share it between our pets. And so we've done a study, and actually within our own business, we have created a derivative or parallel division that tests for canine periodontal disease. Porphyromonas gulae is the bacteria that is the culprit in dog periodontal disease. But about 20% of dogs carry Porphyromonas gingivalis. And we have studies that demonstrate the transmission from pet owner to dog and back again. So it does occur. It's perfectly logical, and understanding that biology addresses why you need to see your patients recurrently, right? Once you clean them up, you knock those levels down, you lower the level of inflammatory burden, but as the biology would have it, these bacteria will grow back, and so that's why you need to see them again, and things change as a function of time. So you make an excellent point, Howard, and these things are pretty obvious when you think about it.
In my 54 laps around the sun, I always see people kiss their dogs on the mouth, but I never see people do that to their cats. I've always had 3 cats. I've never seen a cat owner kissing the cat on the mouth, but you see it all the time with people on their dogs. Do you think it's a bigger problem with dogs? since dogs will come up and lick your face, and a cat is never going to come up to you and start really licking your face?
Well, I've lived 30 laps around the sun with dogs, but none of them have ever been my dog per se. So I've sort of been one of those guys who encountered dogs as an adult and wondered why anybody would kiss their dog. But the point is they do. And I think a lot of people kiss their dogs. But let's get back to the point of cats. A study from just about 3 weeks ago made its way to the New York Times and in the scientific literature that talks about the risk to pregnant women and to owners generally for two concerns. One is cat scratch fever, which is a classic, prenatal concern, but the other is capnocytophagia, a series of bacteria which in periodontal disease is viewed as a low-risk pathogen, but in some people, particularly those who have some degree of immunosuppression, that could be a lethal bacteria. Well, cats carry this in great, great abundance. So if you kiss your cat, you have a risk of transmitting capnocytophagia. And there's a series of species of the bacteria. So a lot of us have it. A lot of us get it from animals. Those who have cat have higher levels. And it's a concern.
And what is more toxic, cat scratch fever or Ted Nugent who sang the song?
Depends on your political persuasion, but I can see them equally being pathogenic.
Oh, that was not all my jokes are funny, but I try hard.
It's hard to dance the cat scratch fever, the disease.
Yeah, and it is amazing. You see it in households all the time. I mean, I can't believe it. I mean, I cannot even comprehend how people have a newborn baby and the mom and dad are both dentists, and you see them in their house and two other dentists come over and they pick up the baby and they kiss it right on the mouth. And it's like, oh my God, the mom and dad are a dentist. The person that just came over for dinner is a dentist. And she just picked up a 3-month-old baby and kissed it on the mouth. I mean, is the entire planet nuts? I mean, the whole planet after HIV understands that below the belt, you can kill each other.
Right.
But the planet doesn't get it because of religion, because below the belt is naughty and dirty and is a sin. But above the belt, it's all clean. And I mean, I just can't believe that you see a dentist come over and kiss a dentist baby couple on the mouth. You're like, did you guys miss microbiology class? I mean, the planet needs to stop doing this.
Well, I would agree. And I guess I've been indoctrinated into the more sort of horrific stories. And so I'll just recount one from my medical school years where sort of the classic professor who had done tropical medicine reminded us that on the hospital, the things that are killing our immunosuppressed patients, those profound cases of bone marrow transplantation, where did that child die of herpes simplex encephalitis? When grandma and grandpa kissed them.
And
those are facts.
And how many people die each year in America in the hospital, going in the hospital for something else, and then gets a disease that they caught at the hospital and that kills them?
Well, that brings up another point. And if you will, let me just expound for a moment. Earlier this morning, I was listening to an article on the BBC that seems to pronounce what the British are very concerned about, which is antibiotic resistance. Okay, and the story of where it all sort of came from is quite simple, but I'm not going to dwell on that. But I am going to point out that, again, in the spirit of community epidemiology and community health, the dentist sits in a privileged position to see the full spectrum of the community, from young to old, sick to well. And from that same vantage of collecting a sample of saliva, you are in a position to identify who has methicillin-resistant Staph aureus and some of these other bacteria. These tests are soon to be forthcoming at OralDNA, and it'll do not only your patients a service, but the community a service as well.
My favorite book on healthcare by a Pulitzer writing guy was Paul Starr in '84, The Rise of the American Healthcare System. It's one of the few books I only read twice. Another Pulitzer Prize on Guns, Germs, and Steel. That was another one I read twice. And he just wrote a new book called Sapiens. It's to die for. But
Right.
Paul Starr just came out with another one, Remedy in Action, the peculiar American struggle over healthcare. But I just want to tell you a real life story in Arizona to tell you where we sit in time. So I'm in Phoenix. If I go to the Intel plant, those employees pull up in their cars, they go in, they take off all their clothes, they'll go shower, they'll go put on a uniform, a mask, deals. They'll walk into that chip factory, which is filters air below 1 part per billion, because one piece of hair on that chip will kill the chip. And then you go across the street to Chandler Regional Hospital, and the cardiovascular surgeon pulls up in his Porsche, gets out wearing his Asics shoes, walks through bird shit, dog shit, everything in the world, walks in the elevator, goes up, and then walks in there, and then washes his hands 20 minutes like he's the Pope doing something with incense on an altar, and then walks in and fillets a man open, and he's got these little booties over his Asics. It's like, why would you prefer to have open heart surgery at an Intel computer plant than in a hospital with a cardiovascular surgeon? I mean, it's like when you, and then when dentists have heart attacks or cancer, then I'll get a phone call like, oh, come on, well, I'll pick you up. We're all going to go visit so and so. It's like, why would 5 healthy dentists all walk into a hospital where all the sickest people in Phoenix, Arizona are to go visit our buddy? I mean, isn't that a classic time to FaceTime him on his iPhone? I mean, and then they bring in their kids. It's like, are you kidding me? You just brought a 2-year-old and a 4-year-old, trudging them through a hospital to invent a friend. I mean, what might he pick up? And then you have other friends who, the daughter went and visited grandma in the hospital. Now she's got this red rash all over her skin and her knee and her arm, and she got it ever since she visited grandma in the hospital. It's like, well, why did you take a 2-year-old healthy kid into a building filled with diseases where everybody is sent if they're sick and dying of something? I mean, we got such a long way to go on this mission. But hey, I want to tell you that I was so excited when you accepted my invitation to be on this show, Ron. I just think you're an amazing guy. I think this is the tomorrow we talked about yesterday. It's here. I'm so excited that you got 6,000 of the 211,000 dentists on board. I hope you do some online CE. I hope you get on the message boards and start talking to these guys about it. What did you say your goal was, to get 50, half of the dentists, or 60%? What was your goal?
60%, yeah, using lab tests.
To get in what time frame?
My goodness, it gets shorter all the time. Let's say 5 years.
Okay, well, I'll do anything to help. I mean, I want my I'd love to come in to this profession as a surgeon who works on molars and leave it as a physician of an oral mouth. I mean, I want to do my part to play on that. I mean, they need to become real doctors. They need to start. I've told dentists, what if we all just start giving flu shots? I mean, what is the government going to do? Are they going to take away the license of 211,000 dentists? Why can't we act like the Teamsters and just say, this is absurd, we're giving flu shots? So either shut us all down. What's that?
Consumers are going to demand it. So convenience is the driver here, economically and otherwise, and it's all about service.
And we should put the patient first. So, hey, thank you for all that you're doing.
I had a blast, Howard. Thank you very much. You're a great guy.
All right. Thank you so much. Have a rocket on. Oh, last question. Are you just loving that 5-0 Vikings and that new $1 billion stadium? I mean, are you just grinning ear to ear every morning when you wake up?
I'm an emerging Viking fan. The last time I was woken from that slumber was in the 70s.
Well, I'm very jealous of your new stadium and your 5-0 record. So congratulations to all you Viking fans.
Thank you very much. I enjoyed it.